Assalamu alaikum wa rahmatullah. Good evening, everyone. Thanks for joining us today in our webinar titled Primary Aldosteronism. This webinar is organized by the Gulf Association of Endocrinology and Diabetes. My name is Raya Mazroui. I'm consultant endocrinologist at Tawam Hospital, and it gives me a great pleasure to moderate this session with the great speakers who are well-known experts in the field of primary aldosteronism. This webinar is sponsored by the Unrestricted Educational Support from Bayers, and we are thankful for them and for their continuous support to our activities. And this activity is accredited 2 CME hours by Dubai Health Authority. During this session, we will have 2 talks followed by industry-sponsored talk, and then this will be followed by 20 minutes for a Q&A session. So I encourage all of you to place your question in a Q&A section in the webinar, and please mention the speaker for whom you are directing your question to. So without further delay, we will start with our first talk tonight, and it's titled Update in Disease Lateralization in Primary Aldosteronism, and our speaker will be Prof. William Drake, who is a well-known endocrinologist and consultant physician at Barts and London NHS Trust. And he is a lead clinician for endocrinology center there. Prof. William, the virtual floor is yours, and please share your presentation.
Can I just check that you can see my slide?
Yes, we can.
Well, good evening, everyone. I'm very pleased to be invited to give this talk on update in disease lateralization in primary aldosteronism. I have no conflict of interest to declare. What we're really talking about is trying to match the supply and demand for lateralization investigations. The current situation is that fewer than 1% of all patients with primary aldosteronism are ever diagnosed. So even though we don't have a great access to lateralization investigations, we are in a sense protected by the huge underdiagnosis rate. So what we really need to be talking about is matching supply and demand for lateralization tests in primary aldosteronism, because if we start to diagnose more patients in primary care and in specialist hypertension clinics, then our endocrine clinics are going to become overwhelmed, and we will really need to be very selective about whom we decide to send forward for invasive investigations with a view to adrenal surgery. So I think before we get on to the nitty-gritty of the update, we really need to have a shift of mindset, because it has become the case in endocrine practice that people regard lateralization and surgery for primary aldosteronism as almost the first prize. And if you don't lateralize, then there's a sort of air of deflation, and you get sent away with a consolation prize of some spironolactone and hope for the best. And I don't think that's quite appropriate. If you have a look at this figure, which is taken from JAMA Cardiology by Hundima et al., and they've done an awful lot of work in this area, what you can see is that the cumulative incidence of atrial fibrillation is contrasted between patients who have an appropriate titration of the renin level versus those who don't. And the first thing to notice is it matters, because you can quite significantly reduce the cardiovascular risk if you titrate the renin to your spironolactone dose. And you do this all the time in other areas of your endocrine practice. You would monitor the TSH in someone with thyrotoxicosis, but we're not really in the habit of titrating the renin in medically treated primary aldosteronism. Maybe we should. The second thing to note from this slide is that the surgical line and the line of the patients who have had their renin titrated are almost the same. So you can say to a patient, I think I can get you into a place of equivalent cardiovascular safety with my pills than I can with an operation. And it's been my experience that if you show this sort of slide or this sort of figure to a patient, they very frequently say, could I start with the pills first, doctor, before you do anything invasive to me? If I show you this slide, it's a rather similar study from the same group. And here we're dividing again the patients who have titration of their renin against those who do not have titration of their renin. And you can see that if you get the renin at a particular level or above, you restore the cumulative cardiovascular risk to that of essential hypertension. And I'm not sure that in routine clinical practice, people are doing this enough. So we need to shift our mindset that surgery is not the first and only prize for patients with primary aldosteronism. Making them safe is. And you can do that as well with your pills as you can do it with the surgeon's knife. The second thing that you need to consider is that you have to be a physician first and an adrenal doctor second. What do I mean by that? Many of you will have read this very important consensus paper from the Endocrine Society, authored by lots of people far more distinguished and far more famous than me. And I've read this paper many, many, many times. And nowhere in the text can I find this: use your clinical common sense. What it actually says is when surgery is feasible and desired by the patient, you should perform adrenal vein sampling. Well, surgery is feasible in virtually anybody if you ask the right surgeon. And somebody with a BMI of 40 who thinks they're going to lose their fatty gynecomastia or their fatty breast swelling by having an operation to stop the spironolactone, they may well desire that operation. It's a different thing to say it's advisable. That's a totally different thing. Now, the reality is you and I come across all sorts of different patients with primary aldosteronism at different ends of a spectrum. And I think if you look at this patient, 29 years old, female, slim, on 4 drugs, and she wants to get pregnant, I think most of us would steer this patient to an operation. But this patient, I'm not so sure. 65 years old, male, a bit heavier, airways disease, some stents in his coronary arteries, and taking 2 drugs. Do you really want to put the patient through invasive adrenal vein sampling just for that? Now, the reality is we see a spectrum of operative risk. And you might think to yourself, well, I'd never send a patient 65 years old, overweight, with COPD and 2 stents. I'd never put a patient through adrenal vein sampling in whom I did not fully intend to offer adrenal surgery. Well, let me acquaint you with the AVSTAT study. This is an NSAT study to which I'm a contributory author, so I'm on the authorship, warts and all. Nearly 5,000 patients with confirmed primary aldosteronism are divided into those who were offered adrenal vein sampling and those who weren't. And of the 3,194 patients who had adrenal vein sampling, there was a pretty good bilateral cannulation rate of 89%. And so those 2,852 people are divided up into those with unilateral primary aldo, 1,055, and the rest who did not have a lateralization adrenal vein sampling. Now, you would think that before the patient was put forward for AVS, it would have been decided that if the patient lateralized, he or she would go for surgery. So the number of surgical referrals of the 1,055 people who lateralize should be virtually all of them. In fact, 12% don't even get a referral letter to the surgeon. So it seems in some people, adrenal vein sampling is being performed for curiosity and then we'll think about it, as opposed to let's really think about it and then offer the adrenal vein sampling. So one of the ways to reduce the queue for venous sampling is to stop doing the test in people who are never going to have an operation. What happened to those 131 patients who lateralized but were not referred? Well, in the paper, the stated reason was because they were elderly in 6%. Well, did you not know they were elderly before you put them up for adrenal vein sampling? In 13%, it was because of comorbidities. Well, surely you knew that before you referred the patient for the sampling. There was no lesion on the CT scan. You must have known that too. The blood pressure was controlled. Well, why was the patient really anxious to have surgery anyway? The patient was normokalemia. Well, we'll leave that aside. So what is it? Why is it that people are having adrenal vein sampling without firmly having established that they're going to go on and have surgery if the problem lateralizes? And to be fair to those people in the study, a primary aldosterone consultation can be quite difficult, and you have to be quite clever to be a primary aldo patient. This is a bit of a caricature of what the consultation might look like, but it's not much of a caricature. You might have a hormonal cause of hypertension, but you might not. We'll do a confirmatory test to see. It might be positive, but it might not be. We might do a CT scan which might show an adrenal nodule, but it might not. We might recommend an invasive test called adrenal vein sampling, but we might not. The invasive test might be technically successful, but it might not. That invasive test might suggest that one adrenal gland is the problem, but it might not. If it is in one adrenal gland, and you have that adrenal gland removed by surgery, we might cure you of hypertension, but we might not. And even if we don't cure you, we hope that you at least reduce your tablet burden. You will reduce the number of pills that you have to take, but we might not. So how do we get a foothold in this consultation? We're having all of these maybes, and it's quite difficult, I think, for patients to get their head around the whole concept of the investigation of this condition. And remember, we're only diagnosing under 1% of them. So one way potentially to introduce a handle into your consultation is to use something called the Primary Aldosteronism Surgical Outcomes Online Calculator. And I'm just going to highlight for you the criteria that you need to measure and document and score, which include the duration of the hypertension, the gender of the patient, the BMI, the defined daily dose, which I'll describe to you in a second, the presence or absence of target organ damage, and by that I mean either left ventricular hypertrophy or microalbuminuria, and the size of the nodule in the adrenal. So just to deal with the defined daily dose, this is a list of half of the tablets. I'm showing you half the list of those that you might prescribe for a patient with hypertension. The list is very long, and some of them are very rarely prescribed, but this is the potential list. And each one of these drugs has a sort of standard unit of prescription, which I'm showing you here. So for amlodipine, the standard unit is 5 milligrams a day, for candesartan 8, and for doxazocin 4. So this patient has what we call a defined daily dose of 3. Now this patient is also taking amlodipine, candesartan, and doxazocin, but this patient is taking double the dose. And so this patient's defined daily dose is 6. Now, in the old literature, both of these patients could legitimately be described as having 3-drug hypertension. But you can see that the patient on the right is taking double the dose. And in the same way that we are trying to standardize outcomes from surgery by means of the PASO score, people are trying to standardize the tablet burden. And you'll increasingly come across this thing called the defined daily dose. It's quite useful for comparing series across the literature. So let's go back to our PASO online calculator. We're trying to introduce something that the patient can get his or her head around when we're discussing whether they want to go forward for something that's invasive, adrenal vein sampling, and something that's even more invasive, abdominal surgery. So let's give this patient 5 years of hypertension, that's 60 months. Let's make her female. Let's make her slim. Let's give her a defined daily dose of 6. She has no target organ damage, and she has a reasonable size nodule in one of her adrenal glands. Using the PASO online calculator, we can look her in the eye and say, I think there's a very good chance that you will completely come off all of your tablets after an adrenalectomy. Let's think of another patient. This patient's had hypertension for 10 years. He's male. He's overweight. Same defined daily dose of drugs. This patient's got some left ventricular hypertrophy, and this patient's got the same size nodule. So much is the same apart from the gender and the duration, and he's not as slim as the other patient. You can look this patient in the eye and say, I have to say it's very unlikely that you're going to come off all of your tablets. Now, the PASO online calculator is not flawless. It's a prediction, not a promise. And it gives you the outcome for the average patient of 100 patients that look the same as one another. But in terms of trying to introduce something and get away from all of those, yes, but we might not, yes, but we may, or yes, but we might not, it can be quite helpful in allowing a patient to get into the consultation. What can you offer me, doctor, before I subject myself to something called adrenal vein sampling and surgery? Now, PASO is not flawless, and the terminology is not flawless. And let's imagine a scenario in which you had a patient who was taking 6 pills for their hypertension. They have an adrenalectomy, and at the end of that, they're down to 1 pill. I think the Oxford English Dictionary would describe that as a success. Maybe you would describe it, and the patient would describe it as a triumph. The PASO English Dictionary describes that as a partial success, because the patient is still taking a tablet after the surgery. So you just need to be a little bit careful between the Oxford English Dictionary speak and PASO speak when you're talking to patients. And just be careful when you talk to them about partial success. That's a terminological tool that we use to compare studies between centres and across the literature. And just be careful that if you say to a patient, I think I'm going to send you to an operation, and I think the operation is going to be a partial success, I think the patient might have something to say about that. So this is a research tool. It's a way of comparing results across centres. Just be a little bit careful with the language when you translate that into a consultation. So there are things that we can do to avoid adrenal vein sampling because we know the answer already. And one of the ways is to use anatomy and age to predict that somebody is highly likely to have unilateral disease. And the standard teaching is that if you have a focal, clearly identified adrenal nodule, and the contralateral gland is normal, and the patient is young, and they have what in the document is described as marked primary aldosteronism, the definition of which is a little bit woolly, then you can avoid adrenal vein sampling because you know that in this patient, the problem is in the right adrenal gland where there's a lump. And if you look at that slide, it looks totally straightforward, doesn't it? Age, unilateral abnormality, contralateral normal, and marked primary aldosteronism. But life is never quite that straightforward. So I'm showing you a few examples here, some sort of package deals, just to give you a flavour as to how you might approach this. So this shows the CT scan that I've just demonstrated to you, a neat focal nodule in the right adrenal, a perfectly normal left adrenal gland, classical cons with hypokalemia. The patient's 37, so technically they're a year or two older than what the guidelines said, but I personally would be fine about sending this patient to surgery without adrenal vein sampling. And the point that I'm going to show you in the next 2 or 3 scans is that you must associate yourself and find yourself a cross-sectional radiologist who is going to love the adrenal and obsess about it and report it meticulously. I'm sure you work with some terrific radiologists who report cancer and liver disease and bowel disease. There are very few people who can really, really get into the detailed anatomy of the adrenal. And my strong suggestion is that you find a colleague who's going to work with you and travel with you on your learning about primary aldosteronism, because you cannot do this without a top-class cross-sectional radiologist who is going to be really interested in and obsess about the adrenal morphology. So let's have a look at another one. 32 years old, the age is fine, The biochemistry is perfect, classical cons. There's a lump in the right adrenal gland, but that left adrenal gland just looks a little bit too knobbly for my tastes, and I cannot declare that to be completely normal. So I have to send that patient for adrenal vein sampling. This patient, a neat nodule again in the right adrenal gland, but those limbs on the left just look a little bit thickened. And it would only be a really experienced adrenal radiologist who's prepared to have feedback, case after case after case, as to whether you as a team got it right or wrong, who would start to call that out and say, I don't think the left's quite normal. So this patient has to go to adrenal vein sampling as well. This patient's got a nice nodule in the left, the right's unequivocally normal, nice and young, but we've needed a saline test to diagnose the primary aldosteronism. It's definitely there, but I don't think you can describe that this as being marked primary aldosteronism, as suggested by the Endocrine Society document. So lots of different combinations, and the key message is to find a radiologist that you work with regularly and to work with somebody who is prepared to have gentle, constructive feedback as to what the outcome was. Not implying criticism that he or she got it wrong, but be prepared to learn with you over 5, 10, 15 years and get really, really good at CT scan reporting. The next way we can potentially cut down on adrenal vein sampling is because we know the answer is going to be bilateral. And there are lots of different prediction models. I'm showing you 4 here on an ROC plot, which a colleague of mine, Sam O'Toole, my old research fellow, did, and which he submitted for publication. He's compared our data with these 4 scores. You don't have to remember all of the detailed scoring system. I'll summarize it for you in an easy to remember clinical lesson, which is that if you're normokalemic and you have unequivocally normal adrenal glands morphologically, it is highly unlikely that you're going to lateralize, and it's highly unlikely that you're going to get yourself into trouble by not offering that patient adrenal vein sampling. But the key to that green box is normal adrenals, and it's another example of which you really need to get close to a colleague who's going to be prepared to say, I think they're unequivocally normal, and that is surprisingly difficult to do. So far, we've covered a few things in trying to match our supply and demand. We've had a shift of mindset. Surgery is not the first prize. It's an option. We've got our spectrum of severity, and we're going to send our 32-year-old young female who wants a pregnancy definitely to surgery. And we're probably not going to send our multi-morbid patient who's overweight, who's had a stent, and who's only on true drugs. We're probably not going to send that patient for surgery. And between, we're going to think about it very carefully. We're going to use potentially our PASO online calculator, not as a promise, but to just help the patient get his or her head around what the odds are. We're going to make use of focal nodularity with normal contralateral morphology in young patients. And we're going to make use of this very useful rule that if you've never been hypokalemic and your adrenal glands look like yours and mine and are normal, it is highly, highly unlikely that you will lateralize. So that patient probably doesn't need a test. So we've still probably got too many patients for the capacity for adrenal vein sampling. And for those people who are not endocrinologists, you might say, what is the fuss about adrenal vein sampling? Why is it so restricted? And why are you making such a big deal about it? Well, the answer is the right adrenal vein, which needs cannulating, is 2 millimeters long and 1 millimeter wide. And it comes off the inferior vena cava at an acute angle. So it is a radiological masterpiece of work to get into that adrenal vein, accessing it from the femoral vein. It's a really, really difficult thing to do. And in the United Kingdom, where I work, there are probably only 6 or 8 people who can do it to a very high standard and get up to that 85, 90% bilateral cannulation rate. On the left, it's much more technically easy because you go via the left adrenal vein, but it's the direct association with the right adrenal vein and the inferior vena cava, 2 millimeters long, 1 millimeter wide, that makes this so technically difficult, which is why we're constantly looking for alternatives to that scarcely available test. And the question I'm posing here is, can we avoid adrenal vein sampling in somebody who, in our heart of hearts, we really think the problem is in the right adrenal gland. She's 43, she's female, she's got hypokalemic hypertension, she's got classical Conn syndrome, she's got a very attractive nodule in the right adrenal gland. But the annoying thing is, she's had a few birthdays too many to offer her surgery without a lateralization test. She's not 35, 36, 37, I'd be okay with that. Aged 43, there is a 3 or 4 or 5% chance that that nodule is a completely incidental, clinically functionless lesion in the right adrenal. Really, the chances are that it probably is the source of the problem. Is there something that we can use just to get us over that certainty line and go for surgery without AVS? And the answer to that question is maybe. The architect of what we're talking about today was Jerome Conn, and if he were to be a time traveller and arrive in your clinic tomorrow, he would get a surprise when you presented the pathology of somebody who underwent an adrenalectomy for Conn syndrome. Because your pathologist would say, you're telling me that this patient is producing too much aldosterone, and aldosterone is made in the outermost layer of the adrenal, the zona glomerulosa. But I'm telling you, Jerome, that this tumour looks as though it's come from the zona fasciculata. It looks like they are cortisol secreting cells. And Jerome Conn, I'm sure, would not believe him or her. Now, what's all this about? This is the sort of thing that we remove when we remove a Conn's adenoma. And the most common mutation that we find, particularly in Caucasians, is a mutation of an inwardly rectifying potassium channel called KCNJ5. Now, if you're a cholesterol molecule and you want to become an aldosterone molecule, you have a long journey ahead of you. And 2/3 of the way along the journey, you need an enzyme called 18-hydroxylase, which converts corticosterone into 18-hydroxycorticosterone. If you're a cholesterol molecule and you want to become a cortisol molecule, you have to take a different route. Now, the important thing about these KCNJ5 mutated adrenal adenomas is they express the enzymatic machinery to make both cortisol and aldosterone. So normally, those two layers just express the enzymes that you need to make the hormone that you're interested in. But these hybrid cells make both sets of enzymes. And the result of that is that cortisol can continue its metabolic journey into a compound that you and I don't really make in health, which is called 18-hydroxycortisol. And this is what we call a hybrid steroid because it requires the enzymatic machinery from two different layers of the adrenal gland. We can measure it. And my thanks to my colleagues in Birmingham who measured it in our match study, which I'll show you in a second, which was published last year. We're looking at the ratio of this hybrid steroid, 18-hydroxycortisol, to cortisol in urine. And what you can see is that those people who carry the KCNJ5 mutation have an elevated level of the hybrid steroid compared to all of the other mutations that we've documented in the study, with just one exception. There's clear blue water between the vast majority of all of the other mutations and the KCNJ5. So let's go back to our patient. She's 43, she's hypertensive, she's hypokalemic, classical Cons, and there's a lump in the right adrenal gland, but dash it, she's 43 years old. What if we were to measure the hybrid steroid in her and be confident that not only is that the source of the problem on the right, but it's almost certainly a KCNJ5 mutation. And the bit of information that is the tantalizing thing is that if you have a KCNJ5 mutation, it is highly likely that you will be completely cured and come off all your tablets. So this is a potential thing to incorporate into clinical practice for two reasons. First, it might avoid in this type of patient an expensive, invasive, and not very available investigation called adrenal vein sampling, but it could also inform the consultation with your patient in whereby you could say, I really think there's a very good chance that you will stop all your tablets altogether. But still, I think we've got a problem because there aren't enough interventional radiologists to do this test. And I'm going to talk to you for the next 2 or 3 minutes about molecular imaging. I'm learning fast about molecular imaging and have been involved in a study for the last 8, 9 or 10 years. I'm getting to know quite a bit about it. But really the trailblazers in the United Kingdom were 3 colleagues of mine, Maurice, HK and Mark. And I would particularly highlight HK Chow, who's a brilliant radiologist, softly spoken, very scholarly, and he has the most experience in the world of reading these molecular images of the adrenal. Now, the principles are that if you have an aldosterone secreting adrenal lesion, I'm showing it to you here in the arrow just underneath the liver there, there's a lot of this going on. Cholesterol all the way down to aldosterone, and you will need a lot of aldosterone synthase to do that, and that enzyme will be very active. That high aldosterone level will suppress the renin, and so the activity on the other side of the adrenal will be very low. There'll be very little aldosterone synthase activity in the contralateral adrenal. And you're familiar with this principle in your endocrine practice because you do a lot of technetium scans or iodine scans, I'm sure, to look at toxic nodules. So here I'm showing you an active lesion in the right hemithyroid, suppressing the left hemithyroid. The same principle applies for molecular imaging of the adrenal. The question is, what's the ligand that we're using for the adrenal? What's the technetium equivalent in the adrenal to the thyroid? And at the moment, there's most experience with an old veterinary anesthetic agent called metomidate. And metomidate binds to the enzymes that synthesize aldosterone and cortisol. So it's non-specific. It will bind to aldosterone synthase and cortisol synthase, which we call CYP11B2 and CYP11B1 respectively. But if we give the patient dexamethasone and we turn off cortisol production, we can convert metomidate into a selective aldosterone synthase ligand because we've taken away the enzymatic activity of the cortisol synthase. And this is the sort of thing we can get. On the left-hand side, you can see a right adrenal nodule, you can see the PET scan and the overlay. And this is the sort of investigation that we've been looking at and comparing with adrenal vein sampling. And in a large number of patients, 142, who had both adrenal vein sampling and metomidate scanning, we've compared their accuracy in predicting the outcome from surgery. This is the study. We confirmed primary aldosteronism, and all patients had both scans in random order. The metomidate PET-CT scan was scored and graded high, low, or medium probability of unilateral primary aldosteronism before the adrenal vein sampling result was revealed and analysed. So that was scored in ignorance of the AVS. The patients then started spironolactone or eplerenone if they could not tolerate spironolactone. We reviewed all the data, and if you had one of those investigations that suggested a high probability of unilateral disease, you proceeded to surgery, and you were followed up at 1, 3, 6, 12, and 24 months. If you did not have evidence on either test of lateralization, you were managed medically. And I'm showing you the results here. I mustn't go into Paolo's time, but I think I'm all right. And what I'm showing you here is that the most common scenario in the yellow was that both investigations concurred and predicted the outcome from surgery. But you can see in the green that metomidate is performing at least as well as the criterion standard adrenal vein sampling in the blue. And if we look at a forest plot, we can see that on declared non-inferiority margin of minus 17.5% is cleared, and we can therefore declare that molecular imaging using metomidate is as good, as accurate, non-inferior to the standard invasive adrenal vein sampling. That's the headline from the study. And at this point, I should acknowledge the fantastic research staff, the junior faculty that delivered this study through the pandemic of 2020 and 2021. They were absolutely outstanding, and without them, nothing would have happened. The problem is that carbon-11 metomidate has a short half-life of only 20 minutes, so you have to synthesize it on site using a cyclotron. You could not synthesize it at one center and ship it to another center. The other problem is that the dexamethasone converts metomidate into a selective ligand for aldosterone synthase. But the problem is some nodules co-secrete cortisol. And so in those patients, the metomidate will bind potentially to some lingering activity of cortisol synthase. So a trap to be avoided with metomidate is the false positive of a nodule that's actually secreting cortisol rather than aldosterone. The second issue, or the major issue with metomidate, is the half-life. And so we have compared a sister ligand, ceto, using 18-fluoro, and compared it with carbon-11 metomidate. And here I'm showing you an example of a metomidate on the left and a ceto on the right in unilateral disease. And I'm showing you an example of bilateral disease, metomidate on the left and ceto on the right. Now, the attraction here is that the half-life of 18-fluoro is about 2 hours, and this opens up the possibility of using ceto in any center that is conventionally using 18-fluoro FDG, for example, which I'm sure is very common in the centers that you work at for cancer imaging. So it may be that here we've got a ligand that can be distributed to different centers and is therefore not confined to the center that does the synthesis. More work to be done with ceto, but we've got preliminary results that we're just analyzing and submitting for publication. Now, the final thing that I'm going to show you is not so much about lateralization, but about the extra information that molecular imaging can give you. Adrenal vein sampling lateralizes the problem. It tells the surgeon to take out the right adrenal gland or the left adrenal gland. But molecular imaging lateralizes and localizes, and that's potentially of interest if we want to treat just the nodule as opposed to removing the whole adrenal gland. And what I'm showing you here is an endoscopic ultrasound scan, and on the end of that endoscopic ultrasound device is a needle, which is going to go through the stomach wall into the left adrenal adenoma that I'm showing you on the ultrasound image. And here's a patient who's enrolled in our study, our pilot study of endoscopic ultrasound, transgastric radiofrequency ablation of just the nodule, guided by the molecular imaging. So here's the patient for drug hypertension. There's the left adrenal aldosterone secreting nodule seen on the pre-ablation scan. He has that procedure that I showed you on the previous scan, an endoscopic ultrasound scan, identification of the nodule, through the stomach wall with the needle, radiofrequency ablation. It takes 10 minutes. And here's the post-ablation scan. The lump has gone, and he has normal blood pressure without medication. So we're now doing a randomized study of total adrenalectomy versus transgastric endoscopic ultrasound-guided radiofrequency ablation. We're about halfway through recruitment, and we'll tell you the results in a year or so. There are other ligands other than metomidate and ceto. One is CXCR4, which is a chemokine ligand, and there is a new aldosterone synthase ligand, which is specific to aldosterone synthase, does not bind the cortisol synthase, so it does not need the dexamethasone, and is therefore potentially attractive because it probably doesn't identify false positives. This scan has only been performed in about 12 or 14 patients. I've put some patients into that study, and I'm a collaborator in that, but that's very early days for that particular ligand. But I think you might hear more of that in due course. So if you wanted me to give you a soundbite, it's not so much that I want to ration the use of AVS, but I think we need to make the use use of AVS more rationale, and I hope I've given you an insight into how we can do that. It all requires multi-center, collaborative investigation and clinical trials, and I would very much welcome the opportunity to discuss the design of those trials, get the opinion of Professor Mulatero on what we've done so far, and I will answer any questions that you have later in the symposium. So I'm very pleased to be invited, and I'll close there.
Thank you so much, Prof. William, for the excellent talk and review. It was really an amazing. And I encourage all the audience and participants to place their question in the Q&A section. I'm glad to announce that we are joined by more than 700 participants. And now we'll move to the next talk, which is titled The New Pharmacotherapy for Primary Aldosteronism. And we are honored to have Prof. Paolo Mulatero with us, who is full professor of internal medicine and director of the School of Specialization of Internal Medicine in University of Torino, Italy. Prof. Paolo, virtual floor is yours, so you can share your presentation.
Okay, thank you. I hope you can see my slides.
Yes, we can.
Okay, thank you for the kind invitation. These are my disclosure, nothing related to these talks, really. Even the Society of Hypertension started to acknowledge that the huge prevalence of primary ALDO is a critical problem in the approach of patients with hypertension. The prevalence of primary ALDO range from around 5–6% in the general hypertensive population, reaching around 20% in patients with resistant hypertension. But if we will take into account all those patients with very mild hyperproduction of aldosterone, not due to the activation of the renin-angiotensin system, we can reach even 20% in the general hypertensive population. And it is widely known that patients with primary ALDO undergo to a higher rate of cardio and cerebrovascular event compared with patients with essential hypertension, even when they are comparable for blood pressure level and other risk factor. When patients are treated by surgery, usually they undergo to a complete biochemical success, that is, they are cured from primary ALDO. By contrast, as Professor Drake shown, just around 1/3 of the cases are completely cured by surgery. However, most of the other display a significant improvement of blood pressure level and the reduction of the number of drugs. And this translates in green here into a reduction of cardio and cerebrovascular risk of the patient treated surgically compared with patients with essential hypertension. By contrast, we can identify two groups of patients under medical treatment with different cardiovascular profile. Those treated, let's say, inadequately because either they don't take the drug or the drug is not given to a dose high enough to cause an increase in renin level. And in yellow, you can see the patient in which the renin is no longer suppressed, meaning that the patient is taking the drug and the dose is good enough to block all the ALDO effect. So there's obviously an underuse, underdosage of the MRA in a subgroup of patients, probably because of the side effect of these drugs. We can have theoretically two strategies for to address the excess of aldosterone. One is blocking the receptor, and another one is inhibiting the synthesis from the precursor DOC. So far, we had only spironolactone, which is a strong antagonist of the mineralocorticoid receptor, but unfortunately is also an antagonist of the androgen receptor, leading to erectile dysfunction and this type of problem in men, and also is a progestin receptor agonist, leading to gynecomastia in men and menstrual irregularities in female, still fertile. We also have a eplerenone that is less potent, is much more expensive, is not available in all countries, and in the only head-to-head trial with spironolactone display a much lower efficacy in reducing blood pressure level. For those who cannot be treated or do not tolerate these two drugs, amiloride is another possibility, but it blocks only the renal action of the aldosterone. At the moment, we have other MRA that are coming into the market or that they are under investigation, and they have a non-steroidal structure. Only one of these drugs have been tested so far in patients with primary aldo. It is the esaxerenone. The other drugs are finerenone, apararenone, and ocedurenone. Esaxerenone is a very strong and competitive binder of the mineralocorticoid receptor. You can see the IC50 is even lower than spironolactone without a significant effect on the other steroid receptor. For the effect on blood pressure, you can see in this meta-analysis that at the dose of 2.5 milligram is not inferior to eplerenone 50 milligram per day, and at the dose of 5 milligrams, so the double of the dose, is superior to eplerenone in reducing systolic, diastolic blood pressure, both office and 24-hour, and in increasing potassium level. It has been tested in patients with hypertension, with or without diabetes, etc. And you can see the effect increase with the time, and is independent if the drug is used as a monotherapy or in combination with calcium channel blocker or with RAS inhibitor. In patients with primary aldo, it displays at the higher dose a reduction of around 18 millimeter of systolic and 9 of diastolic. And this, again, was independent of the concomitant antihypertensive treatment. In a relatively short-term trial, it displayed also to reduce microalbuminuria and the level of brain natriuretic peptide that indicate a sort of volume expansion. Apararenone have a very few studies performed so far, and it has been tested in a phase 2 trial in patients with type 2 diabetes and chronic kidney disease. And you can see in patients that also had hypertension, dose-dependent reduction of the blood pressure level. Finerenone is another MRA with quite a short half-life, and these are being tested in two huge big trials, Fidelio and Figaro DKD trial, in which the drug was tested in patients with type 2 diabetes and chronic kidney disease. And with the outcome, there was in one case renal outcome and the other cardiovascular outcome. And in both trials, the drug, compared with placebo, has been shown to reduce cardiovascular endpoint, in particular heart failure, in the study in which cardiovascular risk was evaluated, and the kidney composite, especially the dialysis events in patient in the trial in which the renal effect were studied. In this type of patient, the drug display a reduction blood pressure level, I would say independent of the dose, or at least in this type of patient. There was a post-hoc comparison using the data from the AMBER and the Fidelity trial, and it seems from this data that finerenone could be less effective than spironolactone in reducing blood pressure. However, I have to say that I was present a few days ago into a Chinese Congress of Endocrinology in which they show a non-inferiority of finerenone compared with spironolactone in blood pressure reduction in patients with primary aldosteronism due to a bilateral disease, so relatively mild or moderate form of primary aldo. Ocedurenone have been tested in patients with stage 3B or 4 chronic kidney disease that were not a target for blood pressure level despite at least 2 antihypertensive medication. 2 doses compared with placebo were used in this trial with the endpoint primary endpoint reduction of systolic blood pressure level. You have to see here that most of the patients were in reality patients with resistant hypertension. And you can see that there was a dose-dependent reduction of systolic blood pressure level in this trial. What about aldosterone synthase inhibitor? The problem with aldosterone synthase inhibitor is that the structure of the CYP11B1 and CYP11B2 gene encoding 11-beta hydroxylase and aldosterone synthase are really very, very much similar, with only 2 residues lying into the exon 5 and 6 that confer the additional activity to aldosterone synthase in position 18, that is 18 hydroxylase and 80 oxidase activity. So if I change these 2 residues of CYP11B1, putting the corresponding residue of CYP11B2, the resulting enzyme is completely able to perform 18 oxidation and 80 hydroxylation and deoxoxidation, transforming corticosterone into aldosterone. So that's why, despite many drugs that have been synthesized that are able to inhibit aldosterone synthase, so far in the market, none of them arrived really to be available for patient treatment. The first that was really studied into the clinical ground was the Novartis compound LCI 699 that was tested firstly in patients with essential hypertension with not a dose-dependent reduction, but a reduction in blood pressure level. And this drug was subsequently tested in patients with primary aldo with an acceptable reduction of blood pressure level. This was the 24-hour, and this was the office reduction of blood pressure level. However, this reduction of blood pressure level was obtained at the price of also inhibiting the cortisol synthesis, both in basal condition and after stimulation with ACTH, and with a huge increase of the precursor 11-deoxycortisol and deoxycorticosterone. So this drug, now called osilodrostat, is now targeted for the treatment of patients with Cushing syndrome. Another more recently studied inhibitor of the aldosterone synthase is baxdrostat. Baxdrostat has been shown to be selective for aldosterone synthase in preclinical studies with inhibition of 11-beta hydroxylase only at the very, very high doses. And this drug has been tested in this trial published in New England a few years ago, and they show that systolic blood pressure were reduced at the intermediate at high dose of the drug, and diastolic blood pressure just at the highest dose of baxdrostat. And this was obtained with, you can see, a reduction of aldosterone level, an increase of plasma renin activity, and no change of cortisol levels. So the drug appeared to be absolutely selective. disappointingly, this drug was not effective in reducing blood pressure in another trial, the ALLO trial, in which patients with hypertension taking a RAS inhibitor alone or together with thiazide diuretic, or alone or with a calcium channel blocker, and there was not a reduction of blood pressure level. I have to say that in this trial, there was a high suspicion of non-adherence in a consistent number of patients included into the trial. But these are the results. Lorundrostat is another aldosterone synthase inhibitor. The company made this very complex trial design, but if we have to simplify, they showed that the drug was able to reduce the blood pressure level significantly. You can see here around 9 millimeter of mercury at the lower dose and 8 at the higher dose, so not the dose-dependent effect in patients with uncontrolled hypertension. So it could have 2 or more drug, and the patient were not a target. Interestingly, the response was particularly high in patients with obesity and in patients already taking a thiazide diuretic in the antihypertensive regimen. The third drug is a derivative of fadrozole. Fadrozole shown ages ago in some studies in vitro to be able to reduce aldosterone synthase, and also to inhibit 11-beta hydroxylase. This drug is an aromatase inhibitor that was used for metastatic breast cancer. And in fact, in patients under treatment, it was possible to observe both basal and ACTH stimulation aldosterone production. The company that is called Damian was able to perform a crystallographic process of enantiomeric separation, resulting in the purification of a drug called dexfadrostat phosphate that only retained the aldosterone synthase activity and none of the aromatase inhibition and none of the 11-beta hydroxylase inhibition. So that this drug was tested in a phase 1 on normal volunteers with 3 different doses, 4, 8, 16 versus placebo. And you can see that in the single ascending dose, the production of ACTH stimulated aldosterone was practically abolished with the different dosage without significant effect on ACTH stimulated cortisol production. And the aldosterone-renin ratio was reduced and potassium level consistently increased. And this was obtained without clinically significant increase of the precursor corticosteroid and DOC. There was, however, an increase. In the multiple ascending dose, again, there was a dose-dependent reduction of aldosterone level, both in basal and ACTH stimulated condition. Cortisol was not affected in basal condition and not in the ACTH stimulated condition, except for the 16 milligram when we observe a small reduction. Despite we did not observe significant change in the urinary metabolite of cortisol and of plasma ACTH. So we decided to perform a phase 2 trial in patients with primary aldosteronism using 4, 8, and 12 milligram dose instead of 16, without comparison with placebo for ethical reason, with a placebo run-in and placebo withdrawal phases of treatment. The primary outcome was the change in aldosterone-renin ratio and in 24-hour systolic blood pressure. We recruited only patients with very florid form of primary aldo, as you can see from the requested cutoff for the inclusion into the trial. The background therapy that was allowed was amlodipine, diltiazem, doxazosine, and verapamil, in order to have no or very low interference with the aldosterone and renin measurement. As you can see, I won't go into detail, all patients recruited display a very florid form of primary aldo. And these are the all those combined result. You can see a 92% reduction of the aldosterone-renin ratio and 11 millimeter of mercury of ambulatory systolic blood pressure and 6 millimeter of diastolic blood pressure. As a secondary endpoint, we observe a reduction of blood pressure level for all the different doses, and similarly a reduction of urinary aldosterone level. In this slide, you can see the onset of the effect of the drug that was very rapid. After 2 weeks of treatment already, the aldosterone-renin ratio was almost near to the baseline, to zero. And after withdrawal, 2 weeks again, and the original level were reestablished. And similar effect can be observed for blood pressure level and also for potassium level. We did not observe a difference in this behavior, whether the patient was with a unilateral disease or bilateral disease, indicating that the drug could also work for patients with unilateral aldosterone-producing adenoma. We did not observe significant change on cortisol level, independent of the dose that was used in this patient, and only a very marginal, clinically not significant increase on DOC and corticosterone. The side effects were really marginal and considered not particularly important by the investigator. So in conclusion, in patients with primary aldo, dexfadrostat produced a rapid and sustained correction of the ARR during treatment. Biochemical correction of the ARR translated into significant reduction of systolic 24-hour systolic blood pressure and correction of hypokalemia, and the drug was generally safe and well tolerated. In conclusion, for all this drug, 4 novel non-steroidal MRA are under investigation. Ocedurenone was effective in reducing blood pressure in patients with chronic kidney disease and hypertension. Finerenone reduced renal and cardiovascular outcome in patients with type 2 diabetes and chronic kidney disease. Esaxerenone was effective in reducing blood pressure in patients with primary aldo and hypertension, plus or minus chronic kidney disease and type 2 diabetes. Apararenone was effective in reducing blood pressure and microalbuminuria in patients with diabetes and nephropathy. 3 novel aldosterone synthase inhibitor are under investigation with phase 3 trial. During the phase 2, dexfadrostat was effective in patients with primary aldo, reducing the aldosterone-renin ratio and blood pressure level. Baxdrostat was effective in patients with resistant hypertension, but not in patients with uncontrolled hypertension. Lorundrostat reduced systolic blood pressure in resistant and uncontrolled hypertension and was more effective in patients with obesity and under thiazide diuretic therapy. I would like to thank all the people who participated into the trial I described, and this is my group from Torino, and thank you for your attention.
Thank you so much, Prof. Paolo, for this interesting talk and overview of the advancing medical therapy for BA. So now we will move to the last lecture, which is the sponsored talk, and titled A Closer Look at the Role of Finerenone in Type 2 Associated CKD. And our speaker is Dr. Raya Saba, who is a consultant endocrinologist and diabetologist at the Advanced Pure Diabetes Center in Abu Dhabi. And I encourage all the participants to place their question in Q&A section, please. So please, Dr. Raya, the floor is yours and you can share your presentation.
Good evening, everyone. You can see my presentation, right?
Yes, we can.
All right. So Professor Paulo helped us understand more about the new non-steroidal mineralocorticoid receptor antagonists. And I will be talking more closely about finerenone, which does not have any current indications for primary hyperaldo, but does have a very clear indication in diabetic kidney disease. And I will try to go over a more practical overview of finerenone. I was asked by Bayer to present this lecture. So as we all know, we do not look at type 2 diabetes as only glycemic control anymore. We are very eager to treat the patient as a whole, to treat the weight of the patient, to treat and try to minimize all possible cardiovascular complications. And as we all know, we are worried about their heart function. We treat heart failure along with our diabetic anti-diabetic medications. And of course, CKD is a major complication when it comes to type 2 diabetes. And we never had a lot of glucose or a lot of treatments that were tackling this issue up until the newer generation glucose-lowering medications, such as the SGLT2 inhibitors and the GLP-1 receptor agonists. And beyond the glucose-lowering medications, currently we do have treatments that will tackle specifically on the molecular level the fibrosis and the inflammation happening in diabetic kidney disease. So we all know that CKD is a huge burden on the patient himself or herself and on the healthcare system. Type 2 diabetics who do have CKD are 2 times at higher risk of MI than those who have type 2 diabetes alone. There are 5 times more cases of heart failure among those with CKD versus type 2 diabetes alone, 3 to 6 times more risk of hospitalization from heart failure, and of course, unfortunately, 3 times more cardiovascular death among those diabetic patients with chronic kidney disease when compared to those who do not have that complication. And looking even at an earlier stage of the diabetic kidney disease, the albuminuria level, patients who have type 2 diabetes with moderate to severe albuminuria, when compared to those who have a normal urine albumin to creatinine ratio, were found to have higher rate of ER admissions, higher rate of inpatient admissions, and obviously higher rates of receiving dialysis in the future. So it is needless to say that early intervention will help reduce cardiorenal risks down the line. And of course, when we talk about early intervention, we need to be talking about early detection. And I think most of the international guidelines, be it endocrine, renal, or even cardiovascular guidelines, they all share the idea that screening for cardiovascular, screening for chronic kidney disease and diabetic kidney disease in type 2 diabetic patients is essential and very important. I think that they all agree on it to be done at least yearly and more frequently in a certain group of patients. And of course, the screening is as simple as checking frequently an estimated GFR for the patient and obviously a urine albumin to creatinine ratio. Because of course, eGFR alone may miss the earlier stages of the diabetic kidney disease, and the UACR is a very simple, straightforward, and accessible test to be done in all clinics. So what we are looking at here is the idea that way before the eGFR drops below 60, which usually catches our attention much more than normal eGFR, way before that stage, the patient is starting to increase his cardiovascular risk. From as little as a urine albumin to creatinine ratio of 10 milligram per gram creatinine, this patient is starting to have an increased cardiovascular risk. And the higher the UACR, the worse the progression of the chronic kidney disease in these patients. So the ADA 2023 guidelines clearly stated in their recommendations that when patients have a very high albuminuria level, they are at higher risk of cardiovascular disease, not only CKD. And of course, they stated that when a patient has CKD and has a urine albumin of more than 300 milligram per gram, a reduction of 30% or greater in his urine albumin is recommended to slow CKD progression. So if we could reach a 30% reduction in our patient's UACR, we might actually be preventing them from a detrimental CKD progression and possibly dialysis and other cardiovascular complications as well. So looking back to the 1980s, we didn't have much therapies available for CKD. Then, of course, antihypertensive treatments were found to be protective from the progression of albuminuria and CKD. So we need to control our patients' blood pressure. Of course, the DCCT in the 1990s described how strict glycemic control would actually help with microvascular complications in general, and among that, the diabetic kidney disease. And then the RAS blockade, the ACE inhibitors, and the ARBs were linked to slowing down of the CKD progression and dropping of the UACR. But for the past 20 years, we did not have any new intervention, and we used to count on glucose control, on RAS blockade, on blood pressure control, weight control for our patients, and observe them thereafter until they slowly progress into severe or delayed stages of chronic kidney disease. But more recently, we were lucky enough to have the SGLT2 inhibitors on board, which were also found to help slow down the progression of these patients, type 2 diabetic patients, into chronic kidney disease. And more recently, a new non-steroidal mineralocorticoid receptor antagonist, finerenone, was approved for the use in diabetic kidney disease, type 2 diabetic kidney disease specifically. And it was found that it has a lot of cardiorenal benefit and has basically changed the therapeutic landscape for us endocrinologists, basically, when we are dealing with type 2 diabetic patients who have CKD. So we've always looked at the hemodynamics of the problem. We always had or targeted hemodynamic control through ACE inhibitors and ARBs. We've targeted metabolic control. We used to do our best with the glycemic control, basically. More recently, we're using SGLT2 inhibitors, GLP-1 receptor antagonists. But no matter what we did, apparently there was still a persistent risk of patients having renal events. So these three trials that looked at the SGLT2, the three different SGLT2 inhibitors currently in the market, they looked at patients who already have some sort of kidney disease, and those patients were already on optimal RAS blockade on the highest tolerated doses of ACE inhibitors or ARBs, and then the different SGLT2 inhibitors were added to their regimen, to their glycemic regimen, and they were compared to other type 2 diabetics on placebo. So it was the canagliflozin, dapagliflozin, and empagliflozin versus placebo in these patients. And despite having these agents remarkably drop the renal events, be it development of kidney failure, a doubling of the serum creatinine, or even death from kidney causes, or progression into end-stage renal disease, progression into dialysis. Of course, there was a dramatic drop in the number of events, but if you look at the three agents, there was still some persistent risk. So despite us trying to do our best in terms of hemodynamic control with the RAS blockade, with the metabolic control, control while choosing very specific glucose-lowering medications, we are still not giving our patients the best possible risk reduction when it came to progression of diabetic kidney disease. So what was missing? And this is where the idea of looking at a different angle of the hemodynamics of this problem, there was inflammation and fibrosis happening in the glomerulus that was neglected or to which we did not have any treatment for years. And this is where the role of the non-steroidal mineralocorticoid receptor antagonist came in to try and minimize this inflammation and fibrosis and maybe help with the a big part of the persistent risk. So what's very important is that nowadays the ADA recommends a multifactorial approach. So it is not a sequential approach. You do not have to start with one agent and then go to the other. It is called the pillar approach. So of course, we need to look at our patient as a whole, glycemic control, blood pressure control, of course, lipid control, and to choose when needed agents with cardiovascular and cardiorenal benefits, such as SGLT2s and inhibitors, and of course, the new approved finerenone, which is the currently only approved non-steroidal mineralocorticoid receptor antagonist for diabetic kidney disease specifically. Again, so many other guidelines have mentioned finerenone to be and recommended it as part of the drug therapies that are needed to minimize progression of diabetic kidney disease. So let's look closer, take a closer look at finerenone. So basically, hyperglycemia, high salt load, oxidative stress, and so many other stressors will increase and activate ligands such as aldosterone, cortisol, and eventually they will even increase the receptor levels to these ligands. And it was found that the overactivation of the mineralocorticoid receptors will actually contribute to the inflammation and fibrosis we were talking about, and eventually more sodium retention and more cardiorenal disease. So finerenone is exactly a receptor antagonist. It will work on the mineralocorticoid receptor level, will block the overactivation, and eventually will slow down the inflammation and fibrosis and slow down the progression of CKD and the occurrence of cardiovascular events. So how does this translate clinically, and what's the data and the evidence behind it? So Professor Paulo touched briefly on the two main studies about finerenone, Fidelio and Figaro. Very briefly, the patients in Fidelio and Figaro were type 2 diabetic patients who had some sort of chronic kidney disease. In fact, if you join them together, they would, as you see, they would tackle almost all patients along all the spectrum of the diabetic kidney disease. Those patients were already on the maximum tolerated dose of an ACE inhibitor or an ARB, and they had a serum potassium of less than 4.8. So in the Fidelio, the primary endpoint was the CKD progression, whereas in the Figaro, the primary endpoint was the cardiovascular mortality and morbidity. And the Figaro had predominantly patients with stage 1 to 2 CKD, while the Fidelio had the more advanced cases, predominantly stage 3 and 4 CKD. And as you see, the primary endpoints were very statistically significantly met. There is a drop in CKD progression by 18% in the Fidelio, and a drop in the CV mortality and morbidity by 13% in the Figaro. And in both trials, finerenone was generally well tolerated. So looking at Fidelity, which was a pooled analysis of both Fidelio and Figaro trials, Fidelity would give us an answer through or over all the spectrum of the diabetic kidney disease. And again, the composite cardiovascular endpoint, there was a 14% relative risk reduction. There was a 23% relative risk reduction in the kidney endpoints, be it time to kidney failure, or sustained decline in eGFR or other kidney-related death. There was a 20% relative risk reduction in the progression into dialysis, and of course, less hospitalization from heart failure. Again, looking at fidelity, 40% of patients had albuminuric CKD with a very normal or relatively normal eGFR. When I say normal eGFR, I mean an eGFR that could go very much unnoticed in our clinics. So 40% of these patients had some sort of UACR that was elevated, but their eGFR was still above 60. And I think this is an important slide for you to translate these data into your clinical practice, because a lot of our diabetic patients belong to this population. Again, in the Fidelity trial, looking at all the pooled analysis, finerenone reduced UACR by 32% between baseline and month 4 when compared to placebo. I will remind you of the ADA 2023 recommendation that if we manage to drop the UACR by 30%, we are actually helping the patients to decrease their progression and their cardiovascular disease risk. And this is the drop that you are getting by finerenone alone, let alone the other addition of other glucose-lowering medication or the RAS blockade we already have in our practice. So when to start finerenone? Quick practical overview. So in the Fidelity trial, again, I mentioned this because when finerenone was initially launched, I was always confused on whether if my patient was not on SGLT2, should I start the SGLT2, wait for 3 to 6 months, repeat the UACR and see if there is any improvement, or should I just start finerenone, etc. Well, after a lot of reading, what I can definitely say is that you do not have to do this sequentially, in the sense that give the patients the medications that could help him. So in the Fidelity, a small percentage, 6.7% of patients were on SGLT2s, and they were able to look at a subgroup analysis of the SGLT2 inhibitors. And adding finerenone to the patients who were already on SGLT2 inhibitors helped drop the UACR by 37%, whereas adding finerenone to a glucose-lowering regimen that did not have SGLT2 inhibitors on board also dropped the UACR by 32%. So there is definitely some synergism in their action. They will help us get a better drop in UACR, but you could definitely choose the medication you want to introduce next based on the best appropriate choice, case by case, for every patient. So I'm going to go over a very simple case, and I chose this case to be so simple and so straightforward because I want to highlight that we might be missing a lot of patients with diabetic kidney disease, and we might not be giving them the appropriate management, although currently we do have a lot of options in hand. So here's a patient from my clinic. He's a 47-year-old male. He's a type 2 diabetic patient, has been diabetic for 6 years, and recently his UACR has been increasing. His current HbA1c is 6.5%. His eGFR is still 74. His UACR is 100 milligram per gram creatinine. His potassium is fine, 4.5. And among his regimen, he already uses SGLT2 inhibitors, and he is already on the maximum tolerated doses of the RAS blockade with a not so bad blood pressure control. So looking at the KDIGO heat map, this patient is in this section where the UACR is moderately increased, and the eGFR is between 60 and 90. And what the heat map usually suggests is for us to monitor this patient. So for so long, we would just monitor these patients, try to do our best, keep pushing glycemic control, control the weight, and try to work around the diabetic kidney disease, kind of hoping this will not progress very quickly. But nowadays, we do not have to monitor. So I chose this patient from this category because all of the other patients who are going to be referred to the nephrologist, such as those here in the heat map with the dark orange, they were going to get some sort of help from the nephrologist. But I do worry about the inertia that us endocrinologists might sometimes have while looking and monitoring these patients before they progress into stages where we will actually refer them to a nephrologist. So nowadays there is something that we could contribute to before these patients getting into severe stages of CKD and having to go to dialysis and other interventions. So looking at the Figaro, I think this patient fits the Figaro eligibility criteria. He does have an early stage CKD. His EGFR is still above 60, and his UACR is in the moderate range. So how to start him on finerenone? So in general, as a general rule, finerenone, or currently branded as Kerendia, you first look at your patient's potassium. If the potassium is more than 5, then maybe this is not the right time to start him on Kerendia. Let's deal with the potassium first. If the potassium is less than 4.8, then Kerendia seems safe to be started. And if the serum potassium is between 4.8 and 5, then you could consider, but you need to look at further case-by-case decision. And then, of course, we need to look in parallel at the EGFR of your patient. So if your patient's EGFR is less than 25, then initiation of Kerendia is not recommended. If the EGFR is more than 60, then you can even start them immediately on the high dose, which is the 20 milligram as a starting dose. If the EGFR is between 25 and 60, better start them on the lower dose, the 10 milligram, and follow up later to see if up titration is possible. And when you start someone on finerenone, you should be checking their potassium and EGFR levels 4 weeks after initiation or 4 weeks after any dose adjustment. And even if there was an interruption of the treatment and you restarted, you still need to repeat potassium and EGFR 4 weeks after. And then 4 weeks after, if the patient was started on a 10 milligram finerenone, you check the potassium. If the potassium is still less than 4.8, if there's no drop in the EGFR beyond 30%, then you are safe to increase the dose to 20 milligram, which is the optimal maintenance dose if achievable. If the potassium has increased but is still within acceptable ranges, you could maintain the current dose you are on. But if the potassium has gone beyond 5.5, so 5.6 onwards, it is better to withhold treatment, deal with your potassium elevation, and then consider reinitiation in certain cases. So again, we started back to my case, we started Mr. FH on 20 milligrams since his potassium was 4.5 and his EGFR was 74. So he was a candidate for a starting high dose. We started him on 20 milligrams. And we were aiming at keeping him at 20 milligram if no hyperkalemia or a severe drop in EGFR happened. So here's a brief follow-up on this patient. In July 2023, he was started on the treatment while his UACR was 100. In August, 1 month later, we repeated the potassium and the EGFR. There were no dramatic changes. We kept him on the 20 milligram. And looking at him today, a few weeks ago, his UACR has dropped by almost 50% and more than 50%. His creatinine has barely bulged. His EGFR has very minimally dropped, and his potassium is still within very acceptable range. So after treatment initiation, EGFR and serum could be measured periodically, as we said, and this way you will adjust treatment of the patients. I think we have mentioned that. The only point I wanted to mention is that as long as the EGFR is still above 15, you can still continue and maintain the treatment. So what about this hyperkalemia? I hear a lot of of endocrinologists or colleagues who are worried about this hyperkalemia and keeping it as an obstacle for them to start their patients on it. The maximal difference that occurred in the mean potassium between finerenone and placebo was barely 0.1 at month 4 in the studies. Some hyperkalemia occurred, and that was statistically significant in the finerenone group. But looking at adverse events with clinical consequences, such as hyperkalemia that led to permanent discontinuation, the difference was minimal. But what about hyperkalemia that led to death? There were no cases whatsoever. So with a good potassium management strategy, and we have a lot of options these days, no hyperkalemia-related death occurred in 13,000 patients over a 3 years median follow-up. Now, note that hyperkalemia risk factors, when you want to start patients on finerenone, you can look at these. So obviously, patients who started with a high baseline potassium are at higher risk. Those who started with a lower eGFR were at high risk. The higher the UACR, the higher the risk of hyperkalemia. And those who were on beta blockade were also at higher risk of developing hyperkalemia. And thank you.
Thank you so much, Dr. Raya. Thank you for the great presentation. Now I invite all the speakers for the Q&A session. We have a few questions. Some of them are directed to the talk given, and some of them actually are a general question around BA. So I will try to direct the question to the speakers based on their lectures, or to all the speakers, and anyone can answer. So starting with you, Prof. William, there was a question in regard to the possibility or the availability of the FCTO commercially, and whether it can be shipped to other countries.
It's a nice thought, but I think that's not practical. The half-life of 18-fluoroceto is only just under 2 hours. So you're probably not going to be able to get it across countries. What will need to happen is that those people that manufacture 18-fluoro FDG will have to get interested in manufacturing this ligand, because they should be able to do the chemical reaction if they have the equipment to manufacture FDG. But I think first we would need to publish the study before people make a case for it to be manufactured and available clinically. But across countries, I think the answer is no. The half-life is only 2 hours. So you could start to talk potentially to the people locally that are making your FDG and mention that in the coming years, you might like to think about manufacturing adrenal ligands. But if the answer is, can you get it from the UK out to the Gulf? Yeah. I'm afraid the answer to that is no.
Yeah. Excellent. Prof. Barito, the other question, what is the difference in terms of efficacy between spironolactone and eplerenone?
The efficacy is around, if we compare milligram to milligram, the efficacy of eplerenone is around 50% of spironolactone. So if the patient is acceptably at target with 50 milligram spironolactone, but it has side effect, you should swap to 100 milligram of eplerenone, roughly. And then, of course, there's an individual different response in one case to the other. Of course, you check blood pressure response and potassium to arrive to the target. And after that, you check renin level as well.
Excellent. Dr. Raya, there is a question, actually more than one question, around the use of finerenone in patients with type 1 and proteinuria. Is there any evidence?
There's still no published evidence about type 1. Most of the studies were about type 2 diabetics, actually, unfortunately, so far.
Excellent. Prof. William, another question in regard to the use of in patient with BA and cortisol co-secretion. For lateralization, in this case, what would you go for or prefer, AVS or molecular imaging?
That's a really good question. There is this issue of the false positive with the molecular imaging with ligands that require the preparation with dexamethasone, because if you can't completely switch off the dexamethasone, then the ligand will bind to CYP11B1, that's 11 beta hydroxylase. On the other hand, there is a theoretical argument that if you're using adrenal vein sampling and you have to divide the aldosterone by the cortisol, you get the normalized aldosterone. There is some argument that you might get an altered result from that by changing the denominator. Now, we've published something on that, which is that it doesn't seem dramatically to affect the outcome, but we are in the process of doing an NSAT study to examine that question in a larger number of patients. So I think it's a theoretical issue that altering the denominator by which you divide the aldosterone has the potential to alter the ratio and therefore the lateralization index. It's something that needs a bigger study than we've done to answer the question definitively. I'd be interested in your views on that, Paolo. It's a potential issue that you.
It is a potential issue, but in that case, if you perform a dexamethasone suppression test before and you know there's a co-secretion of cortisol, you can also use methanephrin to normalize the aldosterone instead of cortisol, and that help in many cases in which you are a little bit confused.
Excellent. So the next question for you, Prof. Paolo, regarding whether the new aldosterone synthetase could be more effective in patients with genetic PA, genetic forms.
Of course, this has to be demonstrated. I expect it will work well in patients with FH2 and 4. We have to see if it's going to work in patients with FH3, in which in many cases spironolactone is not working. So we have to see what happened with aldosterone synthase inhibitor. I have to say for FH1, since the enzyme is hybrid, half CYP11B1, half CYP11B2, we cannot say if it's going to work or not. We have to probe it into a very small clinical trial.
Excellent. Dr. Araya, maybe you addressed this question, but maybe for repetition for those who missed it, how to approach the hyperkalemia after using finerenone and how to manage it?
So as we said, if the potassium increased slightly, we could do dose adjustment or not uptitrate the dose. If the hyperkalemia goes beyond 5.5, like 5.6 onwards, first we stop the treatment and monitor. But you could very safely give potassium binders. And these days we do have very safe long-term use of potassium binders. We do have some patients in common with our nephrologist who are currently on chronic use of finerenone because they're getting the benefit with chronic use of the newer generation potassium binders.
Excellent. Prof. William, there was a question whether there was a difference between ACTH stimulation versus non-ACTH, ACTH stimulation versus no ACTH stimulation AVS. Is there a difference in lateralization?
Oh gosh, how long have you got? We could talk about that for 2 hours, Paolo, couldn't we?
Yes, we do.
Exactly.
People go round and round in circles. I think the fairest thing to say is that there are advantages and disadvantages to both techniques, and you will probably find cases with one technique that you miss with another, and you will probably find cases with the other that you miss with the first. Some people do both. That means it's quite a long procedure, and the catheters are in the adrenal vein, and the patient is on the interventional radiology table for quite a long time. We just use ACTH stimulation. I wouldn't want to say that it's better than non, and those people that say that non-stimulated is definitely better than stimulated, I honestly don't think that either camp has a case to say that they're definitely better than the other. Both are pretty good. but no test is perfect. I don't think one should be dogmatic about this, that people go round and round in circles with this. And the fact that we're still going round and round in circles tells you that there isn't a clear-cut answer. Is that fair, Paolo, do you think?
I agree 100%. I can add, if you have to choose only one of the two, I agree, I would choose ACTH stimulated, personally. I do both, and I have to say that in most cases, the results are coherent, and there's only few cases in which there's a change from bilateral to unilateral, but there are always a patient with the number that are around the cutoff. So it's not a huge difference. And in these cases, I choose according to my clinical judgment. So if it's a clear unilateral disease because it's very frank, florid unilateral PA with hypokalemia and so on and on. And after ACTH is no longer bilateral, I follow the unstimulated. If is a patient with bilaterally normal adrenal gland that does some lateralization in basal and not after ACTH, I follow ACTH.
Amazing. So this is actually answer a question that was placed when there is inconcordance between a non-stimulated and stimulated ACTH. Excellent. So another question was actually a case, and I will address this to all of you. If you could help with us. This is from Prof. Ali Zahrani from Saudi Arabia. He will appreciate your help and consider this a great opportunity for a challenging case that he is dealing with, who is a 32-year-old man with severe resistant hypertension, systolic around 170 to 220, on clonidine, on hydrochlorothiazide, losartan, nifedipine, phenoxybenzamine, and labetalol. Has a 24-hour urine, plasma, and plasma metanephrine were all normal more than one time. His direct renin level were 15 to 16 and aldosterone 20 to 30, and his potassium were in the lowish normal range between 3.3 to 3.6. In CT and MRI, he had pancreatic and renal cyst with a 1.5 centimeter right adrenal nodule that is positive in gallium 68. MRA, Doppler, CT angio are negative for renal artery stenosis. He was kept in ICU for the resistant hypertension 24-hour with intra-arterial blood pressure monitor that clearly showed normal arteries. In another post, he mentioned that this patient also in Aldactone 50 milligram BID, and he is actually positive for VHL gene mutation. So are there any comments from you on further management for this patient with resistant hypertension and an adenoma?
I didn't understand which mutation was positive.
VHL von Hippel-Lindau.
Okay.
So why was that test done? Because he doesn't sound to have any clinical manifestations of von Hippel-Lindau. Why was that? You don't have PO because your chemistry is normal.
He had both pancreatic and renal cyst.
Oh, I see.
Yeah.
Okay. Well, do you want to take the primary Aldo question? The units are different. The one I'm used to. So what are the units there?
I'm not sure about the units, but remember this patient was already in Aldactone as well. So he's already on spironolactone with the serenine. Maybe Dr. Ali can add further comments on the units that are used.
So are all of those tests done while the patient's taking all of those drugs?
I assume it is 10 to 15 micro per liter. These are the units for the renin. Okay, and it is aldosterone 20 to 30 nanogram per deciliter.
I think it's very difficult if the patient's taking all those drugs. It's quite difficult to work out where you are really.
Absolutely. Okay, so there are other general.
You've got three things that raise the renin: spironolactone, an ACE inhibitor, and a diuretic, and you've got one labetalol which lowers the renin. So you don't really know where you are with the patient's biochemistry, I don't think.
Yeah. And also, I would expect if the, let's say, the adenoma or anyway, the primary aldo is responsible for this very severe condition, I would expect aldosterone to be much higher, especially if the patient is taking spironolactone. Maybe he has primary aldo, but is concomitant with either essential hypertension or something else, because it doesn't look to be severe primary aldo enough to cause all this trouble. But it's difficult to judge superficially from this.
Anyway, he is Prof. Ali commenting that he is in every possible antihypertensive, but still not responding in terms of blood pressure control. So I think we have to continue with our questions. So again, for you, Prof. Paolo, is there any difference in the effect in the risk of hyperkalemia, or when with the addition of aldosterone synthase or non-steroidal MRA on top of ACE or ARB, specifically in this group who are on ACE or ARB?
Of course, there's a increased risk of hyperkalemia, adding an MRA on aldosterone synthase inhibitor on top of an ACE inhibitor or NARBs. There are not specific reasons to say there's lower or higher risk for aldosterone synthase inhibitor compared with MRA. What we know from finerenone compared to the other MRA, that it seems to be a little bit less at risk for hyperkalemia compared to the others. And for example, in this study I saw in performing in Chinese patient with primary aldo, there was less frequent normalization of hypokalemia in patient treated with finerenone compared to patient treated with spironolactone, meaning that the effect on the kidney for potassium sparing of finerenone is a little bit less strong compared to the compared with spironolactone. And in fact, finerenone have been developed really to take care about the risk that was observed in patient, for example, with heart failure treated with spironolactone for the risk of hyperkalemia.
Excellent. Actually, we have Prof. Ali joining us directly to discuss the difficult case that he just mentioned. Prof. Ali?
Thank you so much for the opportunity. I am actually struggling with this patient who is currently in the hospital for resistant severe hypertension. The story is as follows. He was referred to me from another colleague in Jeddah, in another city, with history of severe hypertension that needed more than one time admission to ICU with emergency hypertensive crisis. She did actually everything she could, and she did not reach any diagnosis. So she referred the patient to me. Basically, he's 32-year-old man, obese, and his blood pressure, as you just heard, even on 5-6 drugs, it's 170, 180, 200, 220 over 120, 130, 140. We tested him. We did whole exome sequencing, looking actually for genes for hypertension, to be surprised that he has actually VHL, not really one of those rare genes of Liddle's or something else. And then we found that he has manifestation of PHL, pancreatic cyst, renal cyst, and he has hemangioblastoma of the retina. Now, the thing is this, his repeated 24-hour urine metanephrines and plasma metanephrines are normal repeatedly. His renin is on the low side. It is in unit per liter, the direct renin assay. It's around 15, which I think when you convert it to the old units, it's something around 1 to 1.5 nanogram per deciliter per hour, whatever the units are. And his aldosterone is around 20 to 30 on the high side. So the ratio will be suggestive, nothing impressive. Now, the thing is this, and then we did for him gallium 68 PET, and he has 1.5 centimeter right adrenal nodule that is also visible on CT scan and MRI. So I suspected that to be pheochromocytoma, but then catecholamines repeatedly negative. And even if this is pheochromocytoma, I'm blocking him big time with alpha blockade and beta blockade. He was actually on 400 milligram BID labetalol and 20 milligram phenoxybenzamine BID. I essentially blocked any port, if I may call it port, for hypertension. He's on clonidine for central blockade. He is on phenoxybenzamine for alpha blockade, labetalol beta blockade. He's on calcium channel blocker, maximum dose nifedipine. He's on diuretics. He's on losartan and IRB. So I was just asking myself, even regardless of the diagnosis, the underlying diagnosis, this patient is blocked in every possible mechanism of hypertension, and despite that, he is seriously hypertensive. And I initially was even doubting that his blood pressure might be factitious, but we admitted him a few days ago to the ICU because he was having some symptoms, and I took the opportunity to put an intra-arterial blood pressure monitor, and he has severe hypertension. So I am puzzled because I don't know what is the reason for this severe hypertension. Initially, I was thinking that his obesity and insulin resistance may be contributing, and he used Mounjaro, and he lost around 15, 20 kg, but that did not change anything in his blood pressure. So that's basically the story, and I would appreciate any help.
I think my two questions would be, have you done a sleep study? Does he have sleep apnea?
He has sleep apnea and he's on CPAP. That came to my mind initially when he came, and I told him that your blood. My initial impression that this is all due to the severe insulin resistance sleep apnea. Yes, he does, but he is on CPAP and he lost weight big time, and now he is on a huge amount of antihypertensive. He's an extra even pharmacological doses of antihypertensive, and he's not budging. He's not coming down.
And have you had with the VHL mutation that you've documented, have you had a very careful look at his brain and his brain stem?
Yes, we looked at his brain. There is nothing in the brain, but we looked at his fundus. He has hemangioblastoma.
Thanks, Prof. Ali. Just for the sake of time, I think if both Prof. William and Paolo have any input, we can just write it in the notes so we can address the other question if you don't mind.
Sure. Thank you so much.
Thank you so much, Prof. Ali. We have just a few minutes left, and I just need to address other few questions. And then for Prof. Ali case, maybe we can add in our response, the live response or answer to the Q&A. There was a question in regard to the management of primary hyperaldosteronism in CKD patient. A patient who have a nodule CKD, and when they started him in spironolactone, developed hyperkalemia. They could not do AVS because of contrast. So how do you address PA in patient with CKD? Anyone can answer.
I had no many cases of this type. One possibility is to use a very low dose of MRA. So, for example, you can use 12.5 milligram of spironolactone, and in some cases you can use every other day because they tend to accumulate the active metabolite. So you really can target to the potassium level in order to not overtake 5.5 milligram milliequivalent per liter per day, per liter, sorry.
Excellent. Dr. Araya, there was a question in regards to pre-operatively. Do you recommend or do you advise the patient to stop finerenone, and for how long?
I did not have any case, but to think about it, I don't think we need to stop it, but I don't have a very evidence-based answer. I don't know if any others of the professor have an answer to that. But I wouldn't see why we need to stop it prior to surgery. If we've already started it a while ago, we have a stable EGFR, the potassium is stable. I don't see a reason why to stop it.
I agree.
Okay. Excellent. Prof. William, there was a question in regards to BA and the pregnancy. Why sometimes their blood pressure get worse and sometimes would improve?
Well, that's an interesting question. There's a small group of people for whom pregnancy and menopause and puberty leads to an explosive rise in blood pressure, and they seem to have a double mutation in beta-catenin and GNAQ, which is a G protein couple that is linked to aldosterone production, and the interaction with the LH, with the HCG of the pregnancy or the LH of the menopause seems to trigger the ferocious hyperaldosteronism, which is almost always cured by surgery. That's the minority of people who have worsening primary aldo in pregnancy. I don't know that the mechanisms are fully understood, but it's a very serious issue, primary aldo in pregnancy. The obstetric outcomes are not good. And so if you have somebody of childbearing age who is thinking of embarking on a pregnancy, it is a very important consideration about whether you fully investigate them and perform the surgery before they attempt conception. If you inherit them, if you like, or if you meet them when they're already pregnant, your hands are slightly tied with the spironolactone, of course, because the anti-androgen effect means that you can't risk using it if the mother is gestating a baby boy. There is some anecdotal experience of eplerenone in pregnancy. It seems to be safe. And the maternal medicine obstetric physicians that I work with are very happy with the use of amiloride in pregnancy. So I think you should take pregnancy and primary aldosteronism very seriously, because the obstetric outcomes are not good. The generic antihypertensives won't do as good a job as inhibiting the action of the aldosterone, which you can either do with eplerenone. I tend to use amiloride more than eplerenone in a pregnancy, but better still is to identify the problem and remove the adenoma before the patient conceives, because it can be very difficult and the risk of preeclampsia is quite high.
Excellent.
That's fair, Paula?
Yeah.
Agree, fully agree.
Yeah. So we can take one more question for patient with resistant hypertension and bilateral hyperplasia on imaging with raised aldosterone-renin ratio in a young patient. Do we still go for venous sampling and surgery despite CT having bilateral hyperplasia? This is the question. So a young man with resistant hypertension and in hyperplasia on imaging.
If the patient is young, I would try my chance to solve cure the blood pressure, or at least improve with surgery if the AVS lateralized. Of course, the fact that the imaging looks bilateral quite often is bilateral after AVS. So I would say to the patient, the probability of having something useful from AVS is going to be moderate to low. But especially if he's a man, if he's young, I don't think he would like to undergo spironolactone treatment for the rest of his life. So I would try my chance. It's different if he's 65 years old with COPD, as William described before.
Absolutely. Thank you so much. We have 2 minutes left, and I think we covered most of the questions. I don't know if you want to give feedback for Prof. Ali and regarding his case, whether you want to go live in the rest coming 2 minutes, or you would like to just answer him in the comments, whatever you like.
I'd like you to do an MR angiogram of the vessels that are around the brainstem. I've seen a couple of cases in which the presence, or if you like, an artery pressing on the brainstem causes uncontrolled hypertension, and there are, in those particular cases, it was possible neurosurgically to separate the artery from the brainstem, but you need to look very carefully at the relationship between the blood vessels sitting on the anterior surface of the brainstem. It needs a lot of neuroradiological expertise because they are obviously close. But the question is there anything irritating the brainstem? Because you've blocked everything pharmacologically, the patient's lost weight, you've treated the CPAP, you don't have catecholamine excess. As Professor Mulatura says, you don't have enough primary aldo, even if the patient's got it, to explain the patient's predicament. If the patient's got renal artery stenosis, you should be dealing with that with your drugs. So my question would be, is there some neurovascular problem on the brainstem? And that requires a particular MR protocol. So you need to talk about it carefully with your neuroradiologist, but you need to look at the possibility that an aberrant blood vessel on the surface of the brainstem is causing some autonomic dysregulation. That would be my last possibility for that patient.
So we could
Sure.
say,
Thank you so much.
thank you, Prof. Ali. So we could say that in patients who have resistant hypertension on multiple medications, and I would say not generous aldosterone and not completely suppressed renin, despite all this medication and uncontrolled hypertension, we need to think of other causes rather than BA. Could we say that?
The most common cause in the outpatient setting is that the patient is not taking the tablets. But you've got the patient on the ICU, from what you're telling me, so it would be inconceivable that non-compliance with the pills. But I wouldn't want you to do an MR angiogram in every patient that has a high blood pressure as an outpatient, despite taking the tablets, because the reality is they're probably not taking them. And if the patient was an outpatient, I'd send off a urine screen to see if they're actually taking the pills. But you've got a particular situation here in which you've got the patient under your nose in the ICU. So it's inconceivable that that's the explanation, because the patient must be taking the tablets. But in the context of VHL, which does throw up difficult to see hemangioblastomas in the posterior fossa, I'd be taking a really careful look at the anatomy of the brainstem and the midbrain with an MR angiogram in that patient.
We'll do that. By the way, I believe honestly that he has pheochromocytoma. I mean, the 1.5 centimeter right adrenal nodule that is positive on gallium dotatate is most likely pheochromocytoma. But the thing is this, even if it is pheochromocytoma, we're blocking it big time and we're not seeing the response. I mean, he's on phenoxybenzamin 20 TID even, labetalol 400 milligram BID. So that I've never needed that dose for any pheochromocytoma actually. And this patient, despite that, he's still very hypertensive.
And again, at 1.5 centimeter pheo in VHL wouldn't cause that degree of, if you've got normal chemistry, I don't think you can blame that either. I think you need to look at a different mechanism.
We will look at his brainstem. Thank you so much for the input.
Thank you so much, Prof. Ali. Thank you for all our speakers. Thank you so much. It was very interesting webinar, interesting talks and discussion. And we were grateful to have all of you. And thanks a lot. Just a few announcements for all the participants. If you would like to be a member in GATE, it is free till the end of 2024. So you can just scan the QR code displayed in the screen. Additionally, you will receive your CME hours through certificate through email, hopefully by tomorrow. And also you will receive a link for survey. So we will appreciate your feedback so we could improve and plan our future webinars. Thank you so much for all the participants. Thanks, Prof. William. Thanks, Prof. Paulo. Thanks, Dr. Raya, for your talks and participation. And hopefully we could meet you in person in future. Thanks a lot.
Thank you all.
Thank you.
Thank you. Bye-bye.
Thank you so much.
Bye,
And thanks
everyone.
for all the participants.
Bye, William.
Bye-bye, Paolo. Nice to see you.
Bye. Bye.